Hi friends, very good evening to all of you. Welcome to this 25 most important pediatric clinical questions series in which we'll try to help you prepare the pediatric questions for the 28th June, upcoming 28th June FMG exam. While I will also wish you all the best once I finish this session. Before starting the session, I again wish you all the best. You have to be very confident and you have to tell yourself that you have already prepared well for these exams, and if you are confident, half the work is done. The remaining thing is your preparations, which I'm sure you have all gone through very well. So let us start with these questions, and I have tried to very carefully select the questions from the topics which I believe are the most important topics for your exams. So let us start with these questions one by one. One topic that I always tell in my classes, that these are the most important questions for your FMG exams pediatric wise are the milestone questions on milestones. You should be very comfortable, familiar with milestones. Answering questions on milestones is very important. So the first question says a child is able to crawl but is not able to creep on stairs. So he is able to crawl but he is not able to creep on stairs. He has recently learned to sit without support. When the child is made to stand, he can stand, but he cannot stand with support. So although he can stand, but obviously he can stand only with support, but he cannot stand without support. Which of these palmar grasps is the child unlikely to have acquired? So what is important is that you have to first see what is the developmental age of the child according to the milestones that are already given. So what are the developmental milestones that are already given? सबसे पहले the first thing that is given is that the child is able to crawl, but he is not able to creep, and most children are able to crawl by the age of 8 months. They are able to creep by the age of 10 months, which his child is not able to do. So most children are able to crawl by the age of 8 months. He has recently learned to stand without support. So he has recently learned to stand also. So although the child is, he's recently learned to sit without support. So although the child is sitting, the child is not able to stand, because he's saying when the child is made to stand, he can stand with but not without support. So when is the child able to sit? Most children are able to sit at around 5 to 6 months for the first time, and they're able to sit without support most likely by the age of around 8 months. So 8 months onwards, most children are able to sit also without any support. By around 8 to 9 months, they are able to sit in a tripod position also. Now, when the child is made to stand, he can stand with but not without support. So the child is able to stand with support roughly by the age of around 9 months to 10 months. So by the time the child is around 10 months of age, I would rather say 10 months, most children are able to stand. And when they are able to stand by 9 to 10 months, they are standing with support. But when is the child able to stand without support? That is by the age of 12 months. But as you can see here, the child is not able to stand. He is not able to stand without support. Now, the child is able to stand without support somewhere around 12 months. So, his age appears to be less than 12 months, but he's definitely crossed all milestones which appear at around 8 to 9 months. So, what is the best answer? So now, according to me, his developmental age should be somewhere around 8 to 9 months to 12 months. He is not able to perform the milestones of a 12-month-old child, but he is able to perform the milestones. In fact, standing without support appears at 10 to 12 months. So he is able to perform milestones of an 8-month-old child, but he is not able to perform the milestones of a 10 to 12-month-old child. So according to me, the developmental age of the child will be somewhere around 9 months. 8 months wale milestones he can perform, but he cannot perform the milestones of a 10 to 12-month-old child, because most children are able to stand without support somewhere around 12 months. So according to that, ulnar grasp, as I have told in my classes, appears at the age of around, when does the ulnar grasp appears? It appears starting from the age of around 6 to 8 months. When is the radial grasp? Radial grasp is the next to appear. It is known to appear somewhere around 8 months to 9 months. Mostly the pincer grasp appears at the age of 9 months, but pincer grasp that appears at the age of 9 months is an immature pincer grasp. The mature pincer grasp appears at the age of 12 months. So according to me, the only milestone the child is not able to perform, because considering that his developmental age is 9 months, the only he should be able to perform this, he should be able to perform this, he should be able to perform this, but the only milestone he should not be able to perform will be a mature pincer grasp, because mature pincer grasp appears at the age of 12 months. So 12 months wala milestone he will definitely not be able to perform. So you are all absolutely correct. A is the correct answer. जिसने C लिखा है, the one who has written C is a wrong answer, because C is radial grasp, and radial grasp around 8 to 9 months पे आ जाती है, and considering that the child is already 9 months developmental age, so radial grasp should definitely not be the correct answer. We are expecting that radial grasp will be present in the child. Milestones कैसे याद करें? Now milestones याद करना तो is always challenging, but as I've said again and again, if you go through the milestones around 3 to 4 times before your exam, and I'm sure आप एक दो बार, in my classes I generally go through the milestones once or twice and ask you to repeat the milestones. After the classes, I was expecting that at least one time you would go through those milestones. And uske baad, if you have gone through the milestones once and just once before the exam, 4 times if you go through the milestones, I feel they should be sufficiently good enough for you to retain them till the time the exam. तो milestones जो हैं वो चिंता नहीं होनी चाहिए, should not be a cause of worry to you. You should be able to remember the milestones if you go through the milestones at least 4 times. Are you all finding milestones challenging, or after going through the milestones 3 or 4 times, you have been able to remember the milestones? I mean, you have to remember the milestones till just 28th of June right now. So let me see. Are you all able to remember the milestones? And let me see how many of you are not able to remember the milestones. Because there is another question which is on milestones. Are you all able to remember the milestones? If you go through the milestones 3, 4 times, are you all able to remember the milestones? Thank you very much for your comments. It is really very encouraging if I get comments like best teacher of pediatrics. Thank you very much. It's really very encouraging when I get these type of comments from my students. Thank you very much. So milestones, ये नहीं बता रहे हो कि milestones आ गए कि नहीं आ गए. Anyway, most children learn to play a peekaboo game. So when is a child able to learn a peekaboo game? See, again the peekaboo game I told is usually known to appear at the age of, कुछ लिख रहे हैं B, कुछ लिख रहे हैं C. Peekaboo game is this: the child plays a peekaboo game usually at the age of 10 to 12 months. Most children are able to play a peekaboo game at the age of 10 to 12 months. It is not at the age of 5 to 7 months. Most children are able to play a peekaboo game at the age of 10 to 12 months. देखो, very quickly let us remember the milestones. Gross motor milestones में I told you most children are able to sit with support at 5 to 6 months. और मेरे साथ साथ रिवाइज करो, revise with me. Most children are able to sit with support at the age of 5 to 6 months and are able to sit without support at the age of 8 months. So 8 to 9 months children are sitting without support. Then they are able to crawl at the age of 8 months. They are able to creep at the age of 10 months, and most children are able to creep on stairs at the age of 15 months. The child first stands with support at 9 months and he stands without support for the first time, as I told you, by around 12 months. So 10 to 12 months he is able to stand without support. So 12 months most children are able to stand without support. Then slowly the child starts walking with support at the age of 10 to 11 months, and by 13 to 15 months children are able to walk without any support. They start climbing stairs from the age of 2 years onwards. Now when they are climbing stairs at 2 years onwards, they are climbing stairs one step at a time. But by 4 years of age, most children can go alternate foot per step upstairs and alternate foot per step downstairs. उसके बाद फाइन मोटर माइलस्टोन्स पे आते हैं. Most children catch objects using a bidextrous approach at the age of 4 months, and they catch objects using a unidextrous approach at the age of 6 months. Revise with me. Now this is the time when you revise all the milestones with me. So they catch objects with a bidextrous approach 5 months. they catch objects using a bidextrous approach at the age of 4 months, and they catch objects using a unidextrous approach at the age of 6 months. Now, most children are able to utilize or catch objects using a ulnar grasp at the age of around 6 to 7 months. 8 to 9 months, they are able to catch objects using a radial grasp, and by 9 months, the pincer grasp appears. Pincer grasp usually becomes mature by the age of 12 months. अलग अलग प्लेटफॉर्म पे अलग अलग माइलस्टोन्स दिया है, 1 महीना 2 महीना, दिस इज करेक्ट. अलग अलग प्लेटफॉर्म पे अलग अलग माइलस्टोन्स हो सकता है. प्लीज जस्ट फॉलो द माइलस्टोन्स जो आपने जिस प्लेटफॉर्म से करना है. सो देर इज नो नीड टू गो हॉपिंग फ्रॉम वन प्लेस टू अनदर. मोस्टली जो माइलस्टोन्स होते हैं ना, इट इज करेक्ट. Milestones, they will always be about a month or so of difference, because milestones always vary from a child to child. The timing of appearance of milestones will vary, so it is expected that milestone will be different. मोस्टली अगर हमने माइलस्टोन्स पढ़ाया है तो मोस्टली हमने माइलस्टोन्स जो है वो ओपी घई से पढ़ाए हैं. तो प्लीज फॉलो वन प्लेटफॉर्म and just trust that platform. That is what I will like to say. Anyway, let us come back to our uh, revision. So we were revising the fine motor milestones. A child is able to make a tower of 2 cubes by the age of 15 months. He is able to make a tower of around 6 cubes by the age of 2 years, and he can make a tower of around 9 to 10 cubes by the age of 3 years. Then a child can copy a line by 2 years, circle by 3 years, square by 4 years, or 4.5 years, triangle by 5 years, hexagon by around 6 years. Most children can copy a cylinder by the age of 9 years, a rhombus by the age of 7 years. Then children for the first time start cylinder by the age of 9 years. Then children for the first time start turning pages of a book individually, one by one, from the age of 2 years. Language milestones में the first language milestone that is known to appear will be vocalization, that is known to appear by the age of 1 month. Then cooing, most children are able to start cooing by the age of 3 months. Monosyllables appear at the age of around 4 to 5 months, while most children can babble by the age of 6 months. Bisyllables appear at the age of around 9 months, and by 10 months, most children are able to speak meaningful words. A 1-year-old child can speak around 2 to 3 meaningful words, and most children start jargons by the age of 15 months. They can speak in sentences, proper sentences, from the age of around 2 years. Coming now to the social milestones. Social milestones, the social smile appears at the age of around 6 weeks, and most children are able to recognize the mother by the age of around 3 months. Then children can start mouthing by the age of around 5 months. Mirror play develops at the age of around 5 to 6 months. Then children start developing stranger anxiety by the age of around 6 to 7 months. Then children are able to play a peekaboo game by the age of 10 to 12 months. So that was the question. Then children start casting objects by the age of around 12 months. Identification of gender, 3 years. Identification of colors, 3 years. Name identification, 3 years. Riding a tricycle, 3 years. Then children are able to develop right-handedness, left-handedness again by the age of 3 years. A complete bladder control develops at the age of 5 years, and a complete bowel control develops at the age of 4 years. That is why never make a diagnosis of enuresis before the age of 5 years, and never make a diagnosis of encopresis before the age of 4 years. तो मैंने दोबारा milestones, I have revised the milestones once again, and I hope you have revised the milestones with me. So one revision I always do in my class. The second revision I have done today, if you have properly followed me for this revision, so second revision is also done. Now you just have to keep 2 more revisions ready for the milestones, and I can bet you will remember the milestones till the time of your 28th June exam. अभी याद रहे milestones? Did you revise with me the milestones? Should I move on to the next question? Did you revise the milestones with me? Did you all revise the milestones with me? I hope you all revise the milestones with me. Okay, let us come now to question number 3. An infant is being evaluated in a pediatric clinic. During the development assessment of a child, DQ stands for development quotient. DQ stands for development quotient. So the development quotient of the child was assessed, So he's asking development quotient below what value should you suggest that the child has a developmental delay. So this is again something which is very important for NEET PG and is likely now to be asked in FMG also. This is what my feeling is, because it is a quite popular question asked in NEET PG exam. Somewhere around this number of questions can be framed in NEET PG. सबसे पहले first of all let us see what a development quotient is. A development quotient is average age of attainment of a milestone upon the observed age of attainment of a milestone multiplied by 100. This is DQ. So what is development quotient? Development quotient is average age of an attainment of a milestone upon the observed age of attainment of a milestone multiplied by 100. So suppose there is a child who started standing at the age of around 12 months. Now most children, or let us say started standing at the age of 18 months, most children are able to stand, as I told you, stand with support for the first time at 9 months. But suppose there is a child who started standing only at the age of 18 months. So what is the average age when most children are able to stand? It is 9 months. But what is the time when this child started to stand? It was at the age of 18 months. So 9 months divided by 18 months into 100 is 50%. So if the development quotient becomes less than 70%, I've told in my class, it indicates the possibility of a developmental delay. So the definition of a developmental delay, as has been given in many authentic textbooks, is when the development quotient is less than 70%. And what is development quotient? As I've told you, development quotient is average age of attainment of a milestone upon the observed age of attainment of a milestone multiplied by 100. So the development quotient of less than 70%. So most of you have given the answer correctly, D, except one or two. So development quotient less than 70% is indicative of developmental delay. Because see, as I have told in my classes, while growth is seeing how the height, weight, head circumference of the child, mid-arm circumference is increasing, development is all about brain growth, brain development. And best way to assess the development of a child is the milestones. So milestone assessment is an indirect method, indirect measure of the brain. That means if the brain of the child is normal, the CNS is normal, the child will all be attaining the milestones normally. However, as I just now said, and there was a question by one of the students, sir, in different platforms, milestones vary by 1 to 2 months. This is expected, because I've told in my classes the sequence of milestone will not get affected. Sequence of milestones always is cephalocaudal. So all milestones appear in children in a cephalocaudal direction, but the rate of milestone appearance may vary from one child to another child. While one child may start to sit at the age of 6 months, it is expected that another child will be sitting at the age of maybe 7 months or 8 months. While one child starts to stand at the age of 9 months, there might be a possibility another child starts to stand at the age of 8 months. So what you need to know is that when should we say that this is a developmental delay? When there is a significant delay in the appearance of milestones, that is the time when you start saying that this might be a case of developmental delay. And that will be when the development quotient of the child becomes less than 70%. So as you say, the average age and the observed age of milestone, if it is not matching completely, it is still not a developmental delay. Average age upon observed age multiplied by 100. So if the average age and the observed age of the milestones are not matching, it is still not a developmental delay. Some amount of delay is expected. But only when the development quotient becomes less than 70%, that is the time when further evaluation is required. That why is the child having a developmental delay? And a large reason for that, a big reason for that may be that the child may have suffered a CNS insult, which has possibly resulted in the child's brain not taking control of the milestones as is expected in a normal child. So these are the children who should be evaluated further if the child's development quotient is less than 70%. Let us come to question number 4. Question number 4 says all of the following may be associated with breast milk feeding in infants except. So which of these is not associated? Which of these is not associated with breastfeeding? Let me see if you can tell me the answer. Is breastfeeding associated with increased incidence of jaundice? Is breastfeeding associated with passage of golden yellow stools? Is breastfeeding associated with protection from the risk of necrotizing enterocolitis in newborns? And is breastfeeding associated with protection from the risk of transient tachypnea of the newborns? Which of these will not be a consistent statement with breastfeeding's benefits or breastfeeding? So breastfeeding may not be associated with which of these statements? Let me see what your answer is. देखो A तो होना ही नहीं चाहिए. You should not say A as the answer because first of all he's saying except. And I'm sure if you have attended my classes, you should not say A because I've clearly told in my classes that breast milk intake or breast milk feeding is associated with increased risk of jaundice. That jaundice is called as breast milk jaundice. There is another type of jaundice which is due to breastfeeding, which is called as breastfeeding jaundice, but breast milk jaundice is very, very common. So this is definitely associated with increased risk of jaundice, is definitely associated with breast milk. There are certain factors which are present in breast milk which are associated with inhibition of the conjugation of bilirubin in the liver. So it is expected that there will be some amount of jaundice which will be associated with breastfeeding. So children or newborns who are breastfeeding have a higher risk of jaundice in comparison to newborns who are not taking breastfeeding, although that jaundice in majority of cases is not likely to cause any major concern. So you have to remember that also, that jaundice does not usually cause any major concern, but increased incidence of jaundice is associated with breast milk feeding. So ये गलत statement नहीं है. This is actually a correct statement. Let us come to the next statement. Passage of golden yellow stools. Yes, this is correct. If a mother is breastfeeding the child, after the child passes the first 3 days, the child passes those greenish or greenish black stools, which is called as meconium. After that, the child starts passing golden yellow color stools on breast milk. So breast milk feeding is classically associated with golden yellow stools. This is also a correct statement. So A is also a correct statement, B is also a correct statement. Now let us come to statement C. C statement says that breast milk feeding is associated with protection from the risk of necrotizing enterocolitis. If you remember, I told you necrotizing enterocolitis is an abdominal emergency, a gastrointestinal emergency of newborns, primarily seen in preterm babies. And it usually occurs because of intestinal ischemia. And along with intestinal ischemia, it is commonly associated with infections of the gastrointestinal tract. And these infections usually occur when the child is being given formula milk. So not giving breast milk along with prematurity is a very important risk factor for the development of necrotizing enterocolitis. So if the mother is breastfeeding the baby, there is adequate evidence to suggest that if the mother is breastfeeding the baby, she in fact is protecting the baby against the development of necrotizing enterocolitis. Although there might be some other overriding factors as well, such as an extreme premature child who may still develop NEC. But giving breast milk to the child or to the newborn definitely is protective against the development of NEC. So formula feeds अगर दोगे तो NEC का risk बढ़ेगा ही. There will be definitely an increased risk of NEC. So C statement is also correct. The only statement that is incorrect, and I'm sure I've never said this in my class, so you should not have a problem in answering this question. Breast milk has nothing to do with protection against TTNB. Transient tachypnea of newborn is one of the most common causes of respiratory distress in late preterms and in term newborns. And the primary reason for transient tachypnea of newborn, as I've again and again told in my classes, is that there is retention of the fluid inside the lungs even after birth. So whatever fluid is present in the fetal lungs, which should have been removed at the time of birth, that fluid does not get removed. And one of the most common reasons for that fluid not getting removed is that the child is delivered by a cesarean section. So a child who is a late preterm child or a term child who is delivered by a cesarean section has a very high risk of developing TTNB. Now, in this case, breast milk does not provide any protection against TTNB. The mother may be breastfeeding the child, the mother may not be breastfeeding the child. There is no protection against TTNB. So, D is definitely something which is not associated with breast milk feeding. So, question number 4, the answer should be D, because he's asking all of them are associated with breast milk feeding, except D is not associated. Breast milk feeding is associated with increased risk of jaundice. Breast milk feeding is associated with golden yellow stools in the newborn, and breast milk feeding definitely is associated with protection against the risk of NEC. Let us just take a few more points about breast milk, which are important for your exams. So I think will be a good revision for you also. So I told that breast milk, exclusive breastfeeding should be for the time of first 6 months. So exclusive breastfeeding, first 6 months. Apart from this, I've also told that breast milk usually is deficient in with vitamins. Breast milk is classically deficient in vitamin K and in vitamin D. Vitamin K and vitamin D. Therefore, in all institutional deliveries, vitamin K is given at birth. And vitamin D is also started in the newborns after birth and usually continued till 12 months of age, usually. Oral vitamin D. Because vitamin K and vitamin D is classically less in breast milk. Vitamin C deficiency can also occur in breast milk, but only when a mother who herself is deficient in vitamin C, who is having scurvy, for example, is breastfeeding a child. Otherwise, in a well-nourished mother, vitamin C deficiency will not occur in breast milk. So, classically, breast milk is associated with deficiency of vitamin K and vitamin D. Then I have told in my classes that there are 3 forms of breast milk. Immediately after birth, till the milk that is being secreted is called as the transitional milk, when the quantity of or the content of the carbohydrates and the fats will increase. And after that, the mature breast milk is secreted. Now, mature breast milk is secreted after day 14. Now, breast milk content has good amount of lactose, good amount of fats, and a decently good amount of proteins, about 1 gram percent of proteins in mature breast milk, about 4 gram percent of fats, and about 7 gram percent of lactose. Now, protein which is present in the breast milk is much less than the proteins that is present in cow's milk, which is a very good thing, because cow's milk protein uh, puts a lot of load on the neonatal kidney, and the neonatal kidney, being immature, is not able to flush out this large amount of protein load. So about 1 gram percent of protein which is present in the breast milk is good enough for the neonatal kidneys, plus the type of protein that is present in the breast milk, which is primarily casein, and the other type of the protein that is present. So there are various types of proteins that are there, but there are different types of proteins which are good for the baby's digestion, and there are some type of proteins which are not good for the baby's digestion. So casein is, for example, a protein that is not good for the baby's digestion. So that is basically very high in the case of cow's milk. Whey protein, on the other hand, is very good for the child's digestion, and that is present in abundant quantities in the breast milk. So breast milk has high quantities of whey protein and less quantities of casein. Cow's milk, on the other hand, has high quantities of casein and less quantities of whey protein, which is again good for the newborn's digestion. So that is another thing that you should remember. Regarding the contraindications, the absolute contraindication of breast milk is actually galactosemia, and many people say maple syrup urine disease and phenylketonuria. Apart from that, mother who is taking illicit drugs, banned drugs, even the babies of those mothers should not be given breastfeeding. And in addition to this, mothers who are infected with human leukotropic viruses, HTLV1, HTLV2 viruses, Ebola viruses, should not breastfeed the baby. So these are considered definitive absolute contraindications of breastfeeding. Apart from that, there are some relative contraindications also. For example, if the mother is on chemotherapy, mother is on radiotherapy, so these are relative contraindications. But absolute contraindications are the ones that I have told you. So please remember these things. Have you all understood this? Have you all understood the points that I have given about breast milk? And you should all remember these points, because these are the points related to breast milk जहां से कहीं ना कहीं से क्वेश्चन आ सकता है. So you should be very familiar with at least these things that I have told you about breast milk, and start breast milk as early as possible after the child's birth. Coming now to question number 5. So breast milk jaundice, if present, never stop feeding, continue breastfeeding. Yes, it is usually true in majority of cases. It's not a universal truth, but yes, in majority of cases, yes, that is true. Plus TTNB is with cesarean section, very good. So this is what I have told. NEC is due to prematurity and formula feeds, very good. And cysteine and taurine, important for brain growth, and cow has casein, which causes, very good. Galactosemia, mother on cytotoxic drugs, and again, so mother on cytotoxic drugs, mother on chemotherapy. So these are definitely breastfeeding contraindications, but absolute contraindications, as I told you, you should consider mainly galactosemia, phenylketonuria, maple syrup urine disease, mother on these mother taking illicit drugs, banned drugs, and mother who has been infected with HTLV1, HTLV2, Ebola viruses, etc. Plus other contraindications as per the individual cases. Let us now come now to question number 5. Question number 5 says a child is brought with a 2 days history of cola colored urine with a history of sore throat and fever 2 days back. So there is a child who is brought with a history of cola colored urine, which indicates a possibility of hematuria in the child. And the child also had a history of sore throat about 2 weeks back. On examination, the blood pressure of the child is 138 by 74 millimeter mercury, which indicates a hypertension in the child. The child also has periorbital edema and pedal edema. So there is edema which is present around the eyes, and there is also edema, swelling, which is present in the legs. Urine analysis confirms the child has a macroscopic hematuria and a 1+ proteinuria. So there is a macroscopic hematuria and there is a 1+ proteinuria. So there is some proteinuria, but definitely not a significant proteinuria. C3 is low, of glomerulonephritis as well, and it can be seen in cases of nephrotic syndrome as well. So edema can be seen both in glomerulonephritis and nephrotic syndrome. Let us see the causes of edema. This again I have told in my classes, but let us again revise the causes of edema in glomerulonephritis and nephrotic syndrome. See, the main cause of edema in glomerulonephritis, to be very frank, is salt and water retention by the renal tubules. What happens is that whenever there is a glomerular injury, for example, because of inflammation in glomerulonephritis, this causes defective sodium excretion, defective salt excretion. Now, this defective salt excretion as a result of glomerular inflammation results in increased salt and water retention by the renal tubules. Now, when there is increased amount of salt and water retention in the tubules, obviously inside the blood vessels, the hydrostatic pressure will rise, because now there is more and more fluid that is accumulating inside the intravascular spaces, and this causes the fluid to shift out into the interstitial spaces, leading to the development of edema. So the primary cause of edema, which is seen in glomerulonephritis, is renal tubular salt and water retention. So renal tubular salt and water retention, which is sodium and water retention. So therefore, since this is a case of glomerulonephritis, our case is a case of post-streptococcal glomerulonephritis, answer should be C. And most of you have given C. Now let us come to the cause of edema in nephrotic syndrome. Now in nephrotic syndrome, please understand the primary cause of edema was always hypoalbuminemia, not renal tubular reabsorption of sodium and renal tubular retention of salt and water. The main cause of edema in nephrotic syndrome was hypoalbuminemia. Now, as you know very well that in nephrotic syndrome, there is increased amount of excretion of the low molecular weight proteins. In adults, it's a non-selective proteinuria, but in the case of children, it is a selective proteinuria. So low molecular weight proteins are being lost in the urine. Now, one of the low molecular weight proteins that is lost in the urine is albumin. So when albumin is being lost in the urine, this causes hypoalbuminemia, and hypoalbuminemia leads to a decrease in the oncotic pressure inside the blood vessels. So as a result, what happens is it is not able to retain the fluid inside the intravascular spaces, which now moves into the interstitial spaces, leading to the development of edema. So the primary cause of edema in nephrotic syndrome is hypoalbuminemia. This was also called as the underfill hypothesis. However, it has been seen that in many children with nephrotic syndrome, even after correction of albumin, edema did not resolve, and the reason for that was possibly there is another cause which was leading to the development of edema. So if hypoalbuminemia is a cause of edema in nephrotic syndrome, so if you correct the sodium, the albumin levels in nephrotic syndrome, the edema should resolve. But what was seen was that there was a percentage of children of nephrotic syndrome in whom, despite the correction of albumin levels, normalization of albumin levels, the edema did not resolve, which led to the suggestions that there is possibly another reason for the development of edema, and that other reason was again renal tubular sodium and water retention. Because again, what is happening in nephrotic syndrome is, again, it is basically problem related to glomerulus. So when the glomerulus problem is there, the salt excretion, the sodium excretion becomes defective. Then sodium excretion is becoming defective. Then what is happening? That in those cases, there is increased retention of salt and water. So whatever is happening in glomerulonephritis and leading to edema possibly is also contributing to the development of edema in nephrotic syndrome, but the main cause of edema in nephrotic syndrome is hypoalbuminemia. So in hypoalbuminemia, I'll just repeat, albumin becomes low. When albumin becomes low, the oncotic pressure inside the vessels become low. And when the oncotic pressure inside the vessels become low, the fluid starts moving into the interstitial spaces. Now, fluid moving into the interstitial spaces will also lead to development of hypovolemia. And this hypovolemia will again be a trigger for further retention of salt and water, which again increases the edema in nephrotic syndrome. So everything is linked. Hypoalbuminemia leading to the development of low albumin leading to decrease oncotic pressure, increase amount of fluid now leaking into the interstitial spaces from inside the blood vessels. So therefore, resulting in hypovolemia. And when hypovolemia will result, it will again trigger a compensatory salt and water retention, which again will lead to further development of edema. So these things are primarily linked. So I hope now you have understood the primary cause of edema in glomerulonephritis is renal tubular sodium and water retention, while the primary cause of edema in nephrotic syndrome is hypoalbuminemia. Have you all understood these two mechanisms? And now you should not forget these two mechanisms, because again, these two mechanisms as of now has not been asked in FMG exam, but in NEET PG exam, these mechanisms have been asked in one form or the other. So you should know the cause of edema in nephrotic syndrome and the cause of edema in glomerulonephritis. Both are associated with edema, but the mechanism leading to that edema may be different. Now coming to question number 6. Question number 6 says a 6-year-old child is brought for evaluation for recent onset palpable purpura in both legs, severe abdominal pain and joint pain. So there's a 6-year-old child who is brought for evaluation, and the child is having palpable purpuras in both the legs with severe abdomen pain and joint pains. Skin biopsy revealed evidence of leukocytoclastic vasculitis. Leukocytoclastic vasculitis means vasculitis of the small blood vessels, dermal capillaries. Leukocytoclastic vasculitis means small capillaries, dermal capillaries, vasculitis develop in these small blood vessels. So there is evidence of leukocytoclastic vasculitis with predominant IgA immune complex deposits in the dermal capillaries. What is this disorder? First name the disorder, then I will ask the question. What is this disorder? ये कौन सा disorder है? In which there are palpable pavuras in the legs, the child is having abdomen pain, the child is having joint pains, plus the biopsy is showing leukocytoclastic vasculitis. What is this disorder? Very good. The disorder is HSP. Very good. The disorder is Hinoch-Schönlein purpura. Very good. Very good. So the disorder is Hinoch-Schönlein purpura. Hinoch-Schönlein purpura, again, as I've told in my classes, I'll just repeat once again. Rash, the characteristic rash of HSP, which is seen in the dependent portions of the body, that is always the characteristic feature of HSP. But apart from rash, there should be minimum 4 out of these 5 findings. If all of them are present, then it's okay. But at least 4 out of them should be present. So there should be presence of abdomen pain. Sorry, it should be 3 out of 4 findings. So there should be abdomen pain. There should be presence of arthralgias or arthritis. There should be presence of renal involvement, which will be either in the form of hematuria or proteinuria. And there should be presence of biopsy showing evidence of leukocytoclastic vasculitis with IgA deposits. So any child who has evidence of that characteristic rash, the characteristic rash of HSP. And what is that characteristic rash of HSP? The palpable purpuras present in the dependent portions of the body, gluteal region, legs, but usually not present in the upper half of the body. Along with that, 3 or more than 3 out of these 4 findings may be present. If 3 are present, then also the diagnosis of HSP can be made. If all the 4 are present, then definitely the diagnosis can be made. Which are those 4 findings? Abdomen pain, arthritis or arthralgia, then renal involvement, kidney involvement, which can be shown either by the presence of proteinuria or by the presence of hematuria, and either a renal biopsy or a skin biopsy shows leukocytoclastic vasculitis. As I said, leukocytoclastic vasculitis means dermal capillaries or small blood vessels get affected, and there is IgA deposition which is seen in these. That is why this vasculitis, HSP, is also called as IgA vasculitis. So you have correctly identified that what is the disorder. Now, what is the treatment of this disorder? So the treatment of this disorder first depends upon what are the primary manifestations. So see, if the primary manifestation is only a rash along with arthritis or arthralgia and renal involvement or GI involvement, abdomen pains, they are not there, then usually what they say is even a steroid is not important. It's a self-limiting illness. It will resolve on its own. So if there is a rash, and along with rash, to ho gayi, rash will always be there. But along with the rash, there is only, say, for example, arthritis. But there is no GI involvement. Abdomen pain is not a feature. There is no life-threatening complications. There is no renal involvement. In those cases, they say that there is no need to give even steroids. This is a self-limiting illness. If there is very much severe joint pains, in that case, you might give the non-steroidal anti-inflammatory drugs, NSAIDs. But otherwise, no need to give steroids. So steroids are primarily indicated in HSP. They are the frontline drugs, but they are primarily indicated when there is a GI involvement. So suppose abdomen pain is occurring, GI involvement, gastrointestinal involvement is there. Suppose there is renal involvement, proteinuria, hematuria. In those cases, yes, you will have to give steroids, prednisolone, oral, and many times intravenous prednisolone may also be required. And in case there is a life-threatening complication, say for example a severe pulmonary hemorrhage or any life threatening complication, then in that case steroids to dene hi hai, steroids have to be given, but along with the steroids additional drugs immunosuppressives such as cytotoxic DMARDs, cytotoxic disease modifying anti rheumatic drugs, they should then also be added. Otherwise, the frontline drug, if you ask me, one first frontline drug for the treatment of um, Hinox-Schondin purpura, it has to be steroids, prednisolone. Have you understood the treatment, everyone? So see, they are saying, sir, I was confused in cyclophosphamide prednisolone. Confused nahi hona. Please hear what I am saying. See, what they are saying is that in case the child of HSP has only renal involvement or has only GI involvement, has abdomen pain, but does not have any life threatening complication, in that case you have to treat this child with prednisolone only. अब in case renal involvement भी renal involvement severe होती जाती है, if the renal involvement keeps on becoming severe, so then first give oral steroids, later on you can even give IV steroids. But only steroids are required unless and until there is a life threatening complication. Now if the life threatening complication starts occurring, say for example the renal complications become very severe, or say for example a severe pulmonary hemorrhage, any life threatening event, then they say even a steroid alone will not be enough, then you have to add a second drug which is either a cytotoxic immunosuppressive drug, for example cyclophosphamide, a cytotoxic DMARD, disease modifying. That drug has only to be added to prednisolone when there will be any life threatening complication. I hope now you have understood. Have you understood now? So without with only joint involvement, no treatment required, only NSAIDs for joint pain. But for other conditions, renal involvement, for GI involvement, then you have to give steroids, and in case a life threatening complication, then add a cytotoxic disease modifying anti rheumatic drug as well, methotrexate, cyclophosphamide. You should know which are the DMARDs. Have you all understood now? Should I move on to the next question? Now there should not be any confusion, and I think जितना भी मैंने आपको बताया, whatever I told you about HSP here should be sufficient for your FMG exams. Okay. Coming now to question number 7. Which of these features in a newborn are not compatible with extremely premature baby? So which of these features is not compatible? So I have told in my classes premature babies versus post mature babies. So I have told in my classes which are the features of premature babies. So premature babies, as I have told in my classes, a very thin red skin, absence of sole creases, then plenty of lanigo, which are fetal hairs, plenty of lanigo, then poor elastic recoil of the ears, and feeding difficulties to hogi. Feeding difficulties are always there in a preterm baby. So what are the features which will not be seen in a preterm baby? And you are all absolutely correct. Deep sole creases will not be seen in a preterm baby. Preterm babies are associated with absence of the sole creases. Preterm babies are not associated with deep sole creases. Preterm babies have absence of sole creases, so no sole creases or very superficial sole creases depending upon the prematurity. Plenty of fetal hair, lanigo. If you press the ear goes back very slowly to its original position. A very thin and red skin. So these are the features that are seen in preterm babies. Then again, feeding difficulties are common in preterm babies. I told you only after 4 weeks can the child be given breastfeeds. So any child who is less than 34 weeks cannot be given breastfeeds. So 32 to 34 weeks, the child has to be given spoon feeds or Periday feeds. Similarly, 28 to 31 weeks, the child has to be given tube feeds, and less than 28 weeks, the child has to be given IV fluids. So there are definitive problems in feeding babies who are preterm babies. Definitely there are problems that are present in preterm babies. So if you see our question, which of these features in a newborn baby are not compatible? So obviously a deep soul crease will not be compatible with a preterm baby, an extreme premature baby. An extreme premature baby is a baby who is born before 28 weeks. जो बच्चे 28 वीक से पहले पैदा हो जाते हैं, they can be called as extremely premature babies. Roughly 28 to 32 weeks are early preterm babies. Early preterm babies, 28 to 32 weeks. Less than 28 weeks are extremely preterm babies or extreme premature babies. 28 to 32 weeks are early preterm babies. And 32 weeks to somewhere around 34 weeks will be moderate preterm babies. Then 35, 36 weeks is what is called as late preterm babies. After 37 weeks, as I've told, it's a term baby. 37 to 42 weeks is term baby. So should I repeat it once again? This is just for easy remembering. Earlier than 28 weeks is an extreme premature baby, extreme preterm baby. 20 to 32 weeks is an early preterm baby, an early premature baby. 32 to roughly 34 weeks is moderate preterm baby, moderate premature baby. A 35 or 36-week baby is a late preterm baby, late premature baby. And after 37 weeks onwards till 42 weeks is a term baby. And after 42 weeks will be a post-term baby. So that is how you should remember for your exams. एक बार मेरे साथ repeat करो, repeat with me. Earlier than 28 weeks is extreme preterm baby. 28 to 32 weeks is an early preterm baby. 32 to 34 weeks is a moderate preterm baby. Or 35, 36 week baby is a late preterm baby. 37 to 42 weeks is a term baby, and after 42 weeks is a post-term baby. So gestation wise सबको याद रहेगा. Every one of you will be able to remember how I have told you. Okay, coming now to next question. A full-term baby delivered by a cesarean section has a very weak cry at birth. The child is having a poor tone, has irregular breathing and a heart rate of 80 beats per minute. Which of these should be the first step in the sequence of resuscitation? So this is a baby who is delivered. The baby is a full-term baby and the baby was delivered by a cesarean section. So this is a full-term baby and the baby was delivered by a cesarean section. Right now the baby has a very weak cry. He is having a very poor tone and the baby is having irregular breathing and his heart rate is also 80 per minute. Now, out of providing the child warmth and drying the baby, intubating the baby and starting positive pressure ventilation, chest compression and epinephrine, which should be the first step that should be performed in this baby? And most of you are correct. Yeah, exactly. I will also go with A as the correct answer. So start first with providing the. No step of resuscitation will be successful unless and until you start the first step, which is providing the child warmth. So start with first providing the child warmth, dry the baby, because if you skip this step, a wet baby will always lose more heat. So the child will continue to lose heat and will become hypothermic. So no matter what step of resuscitation you are following, the child will not improve. So first provide warmth to the baby, dry the baby so that the baby does not become hypothermic. Then in case the baby is not crying, give a tactile stimulation. In case the baby is right now in apnea, so give a tactile stimulation. After tactile stimulation, now if the child is not crying, start the child on ambu bags, positive pressure ventilation with a mask. So the main indication of positive pressure ventilation with the mask will be when the heart rate of the child is less than 100 per minute. That's the first indication to start positive pressure ventilation. If the child still is not responding, then as I told you, the corrective steps which I told, MR SOPA, mask readjustment, repositioning the baby, then suctioning of the oropharyngeal pathway, then opening the mouth further, increasing the pressure of ventilation, and finally intubating the baby, alternate airways. So intubation should come next. If the child is still not responding, then you come to chest compression. So the indication to start chest compression is when the heart rate of the child is less than 60 per minute. When the heart rate of the child is less than 60 per minute. Heart rate less than 100 per minute is an indication to start ambu bag with a mask, but heart rate less than 60 per minute is an indication to give chest compression along with positive pressure ventilation. And if the child is still not responding, then move on to epinephrine. So this is the sequence you should always follow. Epinephrine, again, the preferred route will always be IV. So preferred route is always IV. And in case the IV route is not available, then alternative route will be the intratracheal route. So preferred route is IV, while the alternative route will be the intratracheal route. So these are some of the things that you should remember for your exams. So just remember the sequence. Start with first putting the child under the warmer, drying the child, cleaning the child's oropharyngeal secretions in case they are coming out, and then in case the child is in apnea, tactile stimulation. After that, if the child is still in apnea, despite giving a tactile stimulation, the child is still in apnea, or the heart rate of the child has fallen to less than 100 per minute, that's the indication to now start bag and mask, positive pressure ventilation with the mask. If the child is still not improving, then start MR SOPA. So MR SOPA is starting the child on corrective measures, which includes mask readjustment, reposition the baby, suctioning the oropharyngeal pathways, then opening the mouth further, increasing the pressure, and then finding alternate pathways. So till now you were giving ambu bag with the mask. Now you can always go in for intubation. So intubate the baby in such cases. Once the child has been intubated, then again continue positive pressure ventilation. If the child is still not responding, then add chest compression to positive pressure ventilation. So the indication for adding chest compression is when the heart rate is less than 60 per minute. And even after that, if the child is not responding, then epinephrine. Epinephrine, the preferred route is IV, and the alternate route is always the intratracheal route. The IV route is usually through the umbilical vein. So the IV route is always through the umbilical vein. For positive pressure ventilation, another thing which is very important for your exams to keep remembering for your exams, another thing which is important is that if the baby is more than 35 weeks, %21 oxygen is enough. But if the baby is less than 35 weeks, then 21 to 30% oxygen is given. So these are some of the things that you should remember for your exams. If heart rate more than 100 and labored breathing, then just oxygen. Yes, very good. And CPAP, very good. So have you all understood these steps of resuscitation? Just follow these steps of resuscitation. And in case any question will be asked in the exam on resuscitation, it's likely to be from somewhere here only. So the sequence in which different steps of resuscitation are given: indication for starting positive pressure ventilation, indication for starting chest compression, preferred route of giving epinephrine, the dose of epinephrine 0.1 to 0.3 ml per kg IV route, 0.5 to 1 ml per kg through the intertracheal route. Okay, coming now to question number 9. Question number 9 says a newborn with an APGAR score of 4 will be categorized as. So yes, I have told in my classes again, APGAR score less than 3 indicates severely depressed child, 4 to 7 indicates moderately depressed child, and more than 7 indicates a normal child. So this child is likely to be a moderately depressed child. So you are correct, this child is moderately depressed child. This is not a difficult question. So less than 3 indicates a severely depressed child, 4 to 7 indicates a moderately depressed child, and more than 7 indicates a normal child. And APGAR score is calculated at 1 minute and 5 minutes after birth. In case the APGAR score at 5 minutes is less than 7, then you keep on measuring the APGAR every 5 minutes till the APGAR score becomes more than 7. This APGAR scoring system after 5 minutes is called as the extended APGAR scoring. So normally you score APGAR at 1 minute and 5 minutes after birth. But if the APGAR score at 5 minutes after birth is less than 7, then you actually do an extended APGAR scoring, which is every 5 minutes keep on measuring the APGAR score till the APGAR score comes in the normal range, which is more than 7. And the criteria for APGAR score is the appearance, color of the child, then pulse, heart rate of the child, then reflex response of the child, grimace, then the activity or the tone of the child, and finally the respiration of the child. So let us now come to question number 10. Question number 10 says a 5-month-old infant, has been brought to the pediatric OPD for a 2 weeks history of clusters of seizures, often developing a sudden, brief, bilateral symmetrical contraction of muscles, particularly involving the flexion of the neck and trunk. So this is a 5-month-old infant. First clue is that this is a 5-month-old infant. He is a 5-month-old infant. Now this 5-month-old infant has been developing clusters of seizures, often developing as sudden, brief, bilateral symmetrical contractions, particularly involving flexion of the neck. Now this is another important clue. There is flexion of the neck. Flexion of the neck drops like this. Video EEG of the child shows a hips arrhythmia. This is the third clue. Video EEG of the child shows a hips arrhythmia. Now these hips arrhythmia are those high voltage disorganized EEG rhythms which are very characteristically seen in infantile spasms. So they are very characteristically seen in infantile spasms. So this is a child who has infantile spasms, which is also called as the West syndrome. Now he is asking which of the following statement is correct for these seizures. So let us see one by one. Combination of steroids with valproate often given to control these seizures. No. Infantile seizures do not respond to valproate therapy. So this is the wrong statement. Commonly seen in children below 6 years of age. This again is an incorrect statement because infantile spasms are commonly seen in infants. So it's wrong to say that they are seen in children below 6 years of age. Head drops are commonly seen. Now this is another clue. Flexion of the necks will be head drops. And these head drops are the reason why these seizures are called as salam seizures. So that's the reason why these seizures are also called as the salam seizures. And usually associated with an excellent prognosis. Again, a wrong statement. It in fact is associated very poor prognosis. There are high fatality rates. A significant number of children may not survive beyond 4 to 5 years of age. Infantile spasms. Infantile spasms are actually most commonly seen in infants, and in infants also they are most commonly seen between 2 to 12 months of age. most commonly seen in infants, but in infants also they are very commonly seen between 2 to 12 months of age. They are characterized by those typical epileptic spasms. Along with the epileptic spasms, these children often have developmental regression, which means there are regression in the milestones. When I say regression, that means after appearance of milestones, normally till some time, there is now disappearance of milestones in the opposite sequence. So whatever milestones have already appeared may start disappearing one by one after a certain age. And then it is associated with the typical EEG, which is called as Hips arrhythmia. And Hips arrhythmia, as I've told you, are high voltage disorganized EEG rhythm. So any child with these features, epileptic spasms, developmental regression, and Hips arrhythmia, this will be typical of infantile spasms. Now these spasms can be either as tonic spasms, then they can be clonic jerks as well, and then they can be those head drops, which are the reason why these are also called as salam seizures. So head drops are very commonly seen in these type of seizures, so they are also called as salam seizures. Prognosis usually is not very good, so usually not associated very good prognosis. They are usually associated rather with a poor prognosis. Now the treatment of choice usually which fits best in these children is hormonal therapy, ACTH. So ACTH is the drug of choice for the treatment of infantile spasms. High dose ACTH, although there have been low dose and intermediate or medium dose protocols also, but high dose ACTH has been used successfully in many children. But again, how is ACTH given? It's usually given as intramuscular injections. So to tell the parents to give intramuscular injections obviously at home is difficult. But nevertheless, this is the drug of choice. Now, we normally have a long treatment that is given for infantile spasms. So around 2 weeks of ACTH, morning, evening doses, followed by then tapering of ACTH for another 2 weeks. So around 4 weeks of total treatment. Alternative treatments which have been given are, say, for example, steroids, prednisolone, but prednisolones are not very preferred because they do not bring the same amount of response as is seen in ACTH. So steroids are not as preferred as ACTH. ACTH is easily the drug of choice for the treatment of infantile spasms. Now there is a third drug, vigabatrin, which has also often been used, and in case ACTH is not given as one of the choices, many people believe that vigabatrin can be considered as the drug of choice for the treatment of these children, especially in infantile spasms which are associated with a neurocutaneous disorder called as tuberous sclerosis. Vigabatrin is very good. In fact, these days vigabatrin along with hormonal therapy started at the onset of infantile spasms is considered to be better than giving hormonal therapy alone. So there is a school of thought that rather than giving ACTH alone, hormonal therapy alone, adding vigabatrin to hormonal therapy at the outset when the seizures are starting in infantile spasms brings a much better response in comparison to giving hormonal therapy alone. However, there are challenges with giving vigabatrin. For example, vigabatrin is known to cause problems in the retina of children. Almost 30% children who are given vigabatrin. So they need to be continuously monitored also very closely because of retinal problems that can occur in almost 20% to 30% cases with vigabatrin. Can occur, does not occur in all cases, but can occur. So that is one of the monitoring that needs to be done. But vigabatrin definitely is for treating infantile spasms with tuberous sclerosis. So when tuberous sclerosis occurs with infantile spasms, then the drug of choice is always vigabatrin. Question number 11. So the answer is head drops. Question number 11. Question number 11 says in a child with fast breathing and early onset cyanosis. So there is a child who presents with fast breathing and early onset cyanosis. A chest X-ray is performed and is shown in the image. So which type of chest X-ray are you seeing? So we have different type of chest X-ray. One is sign of 3, which is seen in coarctation of aorta. Then you have a boot-shaped heart, which is seen in cases of tetralogy of fillet. Then egg on string is seen in children with TGA, transposition of great arteries. Then box shaped heart is seen in children with Epstein's anomaly, and sign of 8 or snowman's appearance is seen in children with supracardiac TAPVR. So what type of picture are you seeing? This is typically an egg on a string appearance. I am seeing some children writing TOF. Please remember, I've told again and again in my classes, TOF always usually has an apex of the heart upwards, not downwards. This is the apex of the heart. In tetralogy of fillet, the typical boot-shaped heart, which is also called in Scour and Sebot, is typically when the apex of the heart is tilted upwards. And that is because right ventricle hypertrophy causes the right side of the heart to go downwards. So the left side of the heart, the apex normally tilts upward. Here you can very clearly see the left side of the heart, the apex of the heart is not tilted upwards, it is tilted downwards. So this is definitely not a case of tetralogy of fillet. I hope you have all understood this. I've told this again and again in my classes. Please don't confuse an egg on string with a um, boot shaped heart. In a boot shaped heart, characteristically the apex of the heart will be tilted upwards usually. While in this case, as you can see, the apex of the heart is tilted downwards. So therefore, this is a case of an egg on string appearance, and hence this is a case of transposition of the great arteries. Coming now to question number 12. Question number 12 says, a child with a history of increasing breathlessness while playing, cyanotic spells and systolic ejection murmur at the left upper sternal border is diagnosed on echocardiogram with the triology of fillet. So this is a child who has triology of fillet. All of the following will be likely cardiac abnormalities in this child, except, so which cardiac abnormality will not be present in a triology of fillet? So I told you that there is triology of fillet, then there is tetralogy of fillet, and then there is pentology or pentad of fillet. So there is triology of fillet, there is tetralogy of fillet, and then there is pentology or pentad of fillet. Now triology of fillet is classically pulmonary stenosis. Triology of fillet is classically pulmonary stenosis. Along with that, there will be a right ventricle hypertrophy, and along with right ventricle hypertrophy, there is an atrial septal defect. So ASD is present in triology of fillet. ASD is not absent. आप में से कुछ लोग आंसर कर रहे हो A. He is saying all of these are present except कौन सा नहीं है triology of fillet में? A cannot be the answer. कौन सा नहीं है? Which is not there. All of the following will be likely cardiac abnormalities in this child, except which will not be the present abnormality. So triology includes pulmonary stenosis, right ventricle hypertrophy, and not VSD. ASD is present. So VSD is not likely to be present in this child. Have you all understood? ASD is not the correct answer. Those who are giving VSD, as the correct answer. Sorry, those who are giving ASD is the correct answer. Have you all understood why ASD is not the correct answer? Do you all know why ASD is not the correct answer? Because he's saying all of these are seen except. So ASD has pulmonary stenosis, right ventricle hypertrophy. Triology has pulmonary stenosis, right ventricle hypertrophy, and ASD. So VSD should not be present. On the other hand, tetralogy of fillet is pulmonary stenosis plus right ventricle hypertrophy plus VSD plus iota overriding the VSD. And in pentology, there will be all four components of TEF along with ASD. So these are the features. अब मेरे को नहीं समझ में आया why some of the students had marked ASD as the correct. मैंने अपनी classes में clearly बताया, I've told in my classes very very clearly that triology of Fallot includes pulmonary stenosis, right ventricle hypertrophy and ASD, not VSD. He's asking which will not be present in triology of Fallot. So VSD will not be present in triology of Fallot. Tetralogy of Fallot is pulmonary stenosis, right ventricle hypertrophy, VSD and aorta overriding the VSD. And then pentology of Fallot is tetralogy of Fallot plus an ASD. First time came across triology, huh? You didn't attend my classes? There is a student who is writing first time came across triology. I'm sure whichever batches I've taught, I very clearly taught about what are the components of triology, what are the components of tetralogy, what are the components of pentology. So whatever face-to-face classes I've attended, Delhi, Jaipur, and whatever online classes I've taught, I very clearly taught. And I think I keep teaching this every session. This not only this session, I keep teaching this every session. I'm very surprised to get that first time came across triology of Fallot. Triology, as the word says, triology, three components. Tetralogy, as the word says, tetralogy. So there are 4 components. And pentology, 5 components. So anyway, now I hope you will not make any mistakes. So now no mistakes. Okay, so first time attending your class. Thanks God. Otherwise, I was a little shocked that okay, so first time attending the class, it's okay. So now clear about triology of Fallot, tetralogy of Fallot and pentology of Fallot. Clear everyone? So let us now come to question number 13. This again is something that I repeatedly tell in my classes, and you can always expect this in an FMG exam. Every second or third FMG exam, they ask this question. Which of the following marker of malnutrition best defines stunting in a child? So I have told markers of wasting, markers of stunting. So this marker of wasting is weight for height, and best marker for stunting is height for age. And the marker which can be used in both wasting and stunting is weight for age. So ye I always tell in my classes, and I hope you have all answered this very confidently. I always tell this in my class. The best marker for wasting is weight for height, and wasting is defined as weight for height which is less than 2 standard deviation below the expected. Similarly, the best marker for stunting is height for age, and stunting is defined as height for age which is less than 2 standard deviation from the expected. While the only marker which can be used in wasting and stunting both is weight for age. I also told that while weight for height less than 2 standard deviation from the expected is called as wasting, weight for height which is less than 3 standard deviation will be called as severe wasting. Similarly, while height for age less than 2 standard deviation will be called as stunting, height for age which is less than 3 standard deviation will be called as severe stunting. Remember these things that I have told in my classes. So weight for height less than 2 standard deviation is wasting, height for age less than 2 standard deviation is stunting, weight for height less than 3 standard deviation is severe wasting, and height for age less than 3 standard deviation is severe stunting. That is why if you remember the severe acute malnutrition definition, severe acute malnutrition, first criteria is bilateral pedal edema, second criteria is weight for height which is less than minus 3 standard deviation. Minus means below. So 3 standard deviation below the expected. The moment there is a term 3 standard deviation which comes in, it means severe. The moment the term 2 comes in, 2 standard deviation, it means abnormal, but 3 means severely abnormal. And 1 standard deviation means deviated from the standard, but still not abnormal. So that is how you should remember. 1 standard deviation, but still not abnormal. 2 standard deviation, now it's abnormal, wasting, stunting. 3 standard deviation, now it is severely abnormal. So severe wasting, severe stunting. The moment we say plus, means above the standard deviation, and the moment we say minus, it means below the standard deviation. So I don't need to say below. The moment the term weight for height minus 3 standard deviation comes, minus का मतलब होता है below 3 standard deviation from the expected. सबको समझ में आ गया? The term wasting, stunting, definitions of severe wasting, severe stunting, and when do the terms 2SD and 3SD should be used. Everyone has understood? Anyone who has a query? So here he is asking, following marker of malnutrition best describes stunting. So since he's saying stunting, height for age, and if it would have been height for age less than 2 standard deviation, it would have been stunting. If it would be height for age less than 3 standard deviation, minus 3 standard deviation, it will be severe stunting. Similarly, weight for height, if it is minus 2 standard deviation, it is wasting, but if it is minus 3 standard deviation, it is severe wasting. Now there should not be any confusion. 1 SD का मतलब है not normal, deviated from normal, 1 SD, 1 standard deviation, but it is not abnormal. 2 standard deviation means now it is abnormal, and 3 standard deviation means it is severely abnormal. Coming now to question number 14. Question number 14 says a 9-month-old child is brought to a pediatric OPD with bilateral pedal edema. So the child has a bilateral pedal edema, and weight for height of the child is below minus 3 Z score. So the moment now I say weight for height is below minus 3 Z score, it now becomes severe wasting. And severe wasting with a bilateral pedal edema, it indicates a severe acute malnutrition. So this is a child who has a severe acute malnutrition. Now because the child is not able to take feeds, is this case of uncomplicated severe acute malnutrition or complicated severe acute malnutrition? So first, I know he has a severe acute malnutrition, but because he is not able to take feeds, he should be considered as a case of complicated severe acute malnutrition. So this is a child who has a complicated severe acute malnutrition. Now for a complicated severe acute malnutrition who is hospitalized, there is a 10-step management protocol that I have told you, which is given by the mnemonic. Shielded CSF. So I have told the child should be given, child should be protected against sugar, low sugar, which is hypoglycemia. Then he should be protected against hypothermia. He should be protected against infections. He should be protected against electrolyte disorders. He should be protected against dehydration. He should be protected against deficiency of micronutrients. Then start cautious feeding, and then increase the calories for a catch-up growth. Then sensory stimulation to keep the child in a playful environment, and finally follow up after discharge. So these are the 10 points of the management which you can remember by shielded CSF. Repeat with me. Low sugar to be managed, S, hypoglycemia management. Then low temperature, H, hypothermia to be managed. I, infections to be managed. Electrolyte disorders to be managed. So which electrolyte disorders to be managed? High sodium to be managed. So give low sodium. Low potassium to be managed. So give high potassium, or give supplemental potassium. And similarly low magnesium to be managed. So give supplemental magnesium. Next, dehydration to be managed, DE, dehydration. So dehydration to be managed, oral dehydration to be managed, orally with the Risomal, and IV by giving IV normal saline, which is normal saline N/2 type of saline mixed in 5% dextrose, or ringer lactate mixed in 5% dextrose. No IV normal saline, no IV ringer lactate, because of high sodium already present in these children. Additionally, deficiency of micronutrients. So D is deficiency of micronutrients. So in deficiency of micronutrients, you can start the child on iron, you can start the child on copper, you can start the child on zinc, you can give folic acid to the child, but iron should never be started in the first week of management. The reason I have told you is that iron always complicates infection management. Many bacterial enzymes require iron as a cofactor. So if iron is given, you are actually helping the bacteria or the viruses or the pathogens to survive. So by giving iron, you are actually complicating the management of infections, and a priority in the first week of management is always infection management. So iron should never be given in the first week. Iron should always be given starting from the second week of management. So he is saying which of these is contraindicated. So iron should not be given in these children. You are all correct. Iron should not be given in these children in the first week of management. So sugar management, hypoglycemia, hypothermia, infection management, electrolyte disorder management, dehydration management, management of the deficiency of micronutrients. Then C, start cautious feeding, low calories, increase the calories then for a catch-up growth. Then sensory stimulation, S, and follow up after discharge. So this is a 10-point program that is given for these children. I hope you have all understood. So these 10-point programs that are given for these children is given by the mnemonic shielded CSF. Coming now to question number 15. A preterm baby delivered at 30 weeks gestation shows poor tone and cranial ultrasound confirmed increased echogenicity in the periventricular regions bilaterally, which progressed to cystic lesions by 3. So this is the first clue, is this is the preterm baby. And this preterm baby had a poor tone and cranial ultrasound confirmed increased echogenicity in the periventricular region, which indicates to the development of a damage to the periventricular lesion, which later turned into cysts in the periventricular region. So what is that damage in a preterm who possibly has a perinatal asphyxia? What is that damage to the brain called as? First tell me, what is that damage to the brain called as? What is that damage to the brain of a preterm child who did not get enough amount of oxygen? What is damage to that brain called as? Let me see first you have understood that or not. Then give me the answer. What is that damage to the brain called as? So whenever there is a perinatal asphyxia, that means whenever there is oxygen deprivation to the brain. So there are separate type of brain injuries that develop in a term child, and separate type of brain injuries that develop in a preterm child. Only one correct answer I've got. What is that specific type of injury as a result of oxygen deprivation to the brain of a preterm child called? Periventricular leukomalacia. And you are seeing that in this child there is echogenicity in the periventricular regions, which later progresses to cystic lesions. जो शुरू में पेरीवेंट्रिकुलर ल्यूकोमलेशिया डेवलप होता है, शुरू में द नेक्रोसिस, द इनिशियल नेक्रोसिस दैट डेवलप्स इन द पेरीवेंट्रिकुलर रीजन is called as a periventricular leukomalacia. That area starts getting necrosed, liquefied, and slowly their cysts will start developing. Then that condition later on will be called as cystic periventricular leukomalacia. So इस बच्चे में, in this child now, a cystic periventricular leukomalacia is also developed. So the initial damage that occurs to the periventricular region is called as a periventricular leukomalacia. So that area becomes soft in the periventricular white matter because of liquefaction, necrosis. Later on, इतना soft हो जाता है कि necrosis starts developing in those areas and ultimately cysts develop, and that is the time when this is now called as cystic periventricular leukomalacia. So whenever there is oxygen deprivation to the brain of the child, of a newborn, the preterms usually develop only this type of injury. Characteristic injuries seen in preterms. Terms में अलग-अलग type की injury होगी. In terms there are other types of injuries. Terms में there can be selective neuronal necrosis. So rather than having a complete damage to the periventricular region, only selective neurons can get damaged. Terms may, because of oxygen deprivation, they can be only focal necrosis. or focal necrosis or focal infarcts. Focal infarcts means only selective regions get affected. In selective neuronal necrosis, only selective neurons are damaged. In focal infarcts, only selected regions are damaged. And they may also be parasagittal infarcts. They might be parasagittal. Parasagittal means this is the sagittal region. So along the sagittal region, parasagittal region, infarcts can develop. So terms may, whenever there is oxygen deprivation to the brain in a term newborn baby who is delivered, there can be 3 different types of injuries to the brain. But preterm do not have 3 different types of injury. Preterm have only one characteristic type of injury, and that injury is a periventricular leukomalacia. A term child can have 3 different types of injuries. Either only selected neurons get affected, we call it as selective neuronal necrosis, or focal infarcts develop in specific regions, or there are infarcts which develop along the sagittal. This is the sagittal region. So along the sagittal line, there are infarcts that can develop. But preterms में ऐसा नहीं होता. Preterms में only one type of necrosis develops when there is oxygen deprivation, and that is periventricular leukomalacia. And these children, when have periventricular leukomalacia, they develop which type of cerebral palsy? They develop spastic diplegia. And I think many of you have given the correct answer, but बहुतों ने C भी answer किया. Dyskinetic cerebral palsy will not develop in a preterm child as a result of periventricular leukomalacia. I've told in my classes, periventricular leukomalacia in preterms. I've told in my classes again and again. और इतनी बड़ी hint है, there is such a big hint. Increase echogenicity in the periventricular region, such a big hint. Plus a preterm baby. I think you can clearly connect the two together. A preterm child, jiski poor tone is there. Poor tone means very clearly that the child had some type of perinatal asphyxia. Complication hui hai, tabhi the poor tone hai. Otherwise, if there is no complication, the child will be crying normally, having a normal good tone. So any baby after birth who is a preterm baby and has poor tone, that means there was some complication which affected the baby's brain. Now, if the baby's brain is affected, lack of oxygen is there, and this is a preterm baby, the chances are that the periventricular region will primarily be affected, which was seen in the ultrasound also. When cranial ultrasound was done, it was confirmed that periventricular region was affected. So that led to or will lead to which type of cerebral palsy in the future? It will lead to a spastic diplegia. Terms में ऐसा नहीं होता. Terms में there are different types of injuries that can develop, a wide range of injuries. Sometimes only selective neurons can get defective. So necrosis of only selective neurons, regions nahi, only selective neurons can get necrosis. Or zyartar, whenever selective neuronal necrosis occurs, those neuronal necrosis usually occurs primarily in the basal ganglia region. So primarily which neuronal necrosis in terms will develop? It will develop in the basal ganglia region. Or basal ganglia region mein which type of cerebral palsy develops? I told you, dyskinetic. So whenever a term newborn has a selective neuronal necrosis, the chances are he will go on to develop dyskinetic cerebral palsy. Are you getting the point that I am trying to make? एक बार समझ गए, कभी भूलोगे नहीं. Whenever selective neurons are necrosed because of oxygen deprivation in a term newborn, those selective neurons which are affected will usually be affected in the basal ganglia region. And if you remember in my classes, I told you that when basal ganglia gets affected, which type of cerebral palsy develops? It leads to a development of dyskinetic cerebral palsy. So in those term babies in whom there was a perinatal asphyxia and selective neuronal necrosis occurred, it will lead to a dyskinetic cerebral palsy. Focal infarcts jab hote hain, focal infarcts. So those focal infarcts, if they are in the right side, if they are on the right side, a left-sided palsy will develop. if the focal infarcts are on the left side of the brain, a right side palsy will develop. So whenever there will be focal infarcts, it will lead to a spastic hemiplegia. You have understood the point? You have understood the point. Focal, I said selective regions are now getting affected, not selective neurons, regions. Now, if the right region is affected, left-sided palsy will develop, and the left region will be affected, right-sided. So, whenever there are focal infarcts, there will be development of a spastic hemiplegia. And parasagittal infarcts, finally, here. So, here basically the lower limbs and upper limbs, all the columns are present here. So whenever parasagittal infarcts will occur, then a quadriplegia, that the lower limbs will also get affected, upper limbs will also get affected. Quadriplegia, spastic quadriplegia will develop. So now you have understood. Preterm periventricular leukomalacia leads to a spastic diplegia. Terms में selective neuronal necrosis leads to a dyskinetic cerebral palsy. Focal infarcts will lead to a hemiplegia, and parasagittal injuries will lead to a quadriplegia. ज़्यादा conceptual तो नहीं हुआ? I hope it is not too conceptual for you. But I think if I was explaining, I thought I will well explain this right now, so that this gets embedded in your mind. अगर ज़्यादा conceptual लग रहा है तो छोड़ दो, फिर से periventricular leukomalacia और leads to spastic diplegia, remember. But I thought, since I'm telling you this, it will be better if you remember. I've already told you in preterms what type of cerebral palsy will develop, diplegia. So just as well tell in terms which type of cerebral palsy will develop. Question number 16. Now, question number 16 says a child has a history of year-long chronic productive cough with viscous mucus accumulation and frequent chest infection. So there is a child who has a history of year-long productive cough, and the child also has a thick mucus accumulation, frequent chest infections. He is diagnosed now with cystic fibrosis. The child has been diagnosed with cystic fibrosis. Now he is saying all of the following statements about the disorder are correct, except, so which disorder he is asking is not correct about cystic fibrosis? Chromosome primarily affected, mutation causes defective calcium channels, sweat duct is not blocked, children can develop diabetes in the adolescent period. He is asking which of these statements is not correct. So if you ask me, very good. So if you ask me, this is a correct statement. If you ask me, this is also a correct statement. This is also a correct statement. Absolutely right. Mutation does not lead to defective calcium. It leads to defective chloride and defective sodium channels. So you are all right. You are all correct. I was just thinking whether you will be a little confused about this, diabetes. Is cystic fibrosis really associated with diabetes development also? Answer is yes. You know, there is a high risk of developing adolescent diabetes in children who have cystic fibrosis. Remember this. And that is why all children who have cystic fibrosis or who are diagnosed with cystic fibrosis, it is recommended that starting from the adolescent period, 10 years onwards, they should every year undergo their sugar test, so that they are detected with diabetes in case they develop diabetes. So all children with cystic fibrosis, after 10 years, every year they should get their sugar test done, glucose tolerance test done, to check for diabetes. अच्छा, the reason why diabetes is known to develop in cystic fibrosis, आप पूछ सकते हो कि सर cystic fibrosis आपने बताया था, you told it's a duct problem. ducts get blocked in cystic fibrosis. So obviously pancreatic duct is getting blocked. So diabetes is an endocrine problem. It's not a problem of the exocrine pancreas. It's a problem of the endocrine pancreas. But please understand that when the ducts get blocked in the pancreatic ducts get blocked in cystic fibrosis, the problem starts from there only. So when the pancreatic ducts get blocked in cystic fibrosis, the pancreatic secretions inside the ducts, they accumulate. This is known to lead to inflammation, which gradually damages the beta cells. And when the beta cells get damaged, gradually the insulin production after 10 years starts reducing down. So this is one mechanism why diabetes can develop in children with cystic fibrosis. I'll repeat again. Whenever the pancreatic ducts get blocked in cystic fibrosis, the pancreatic secretions, they accumulate inside the ducts, which leads to a secondary inflammation inside the ducts. And this inflammation inside the ducts is known to cause gradual damage to the beta cells of the pancreas, which releases insulin. And that is why the insulin secretion gradually starts reducing down after the age of 10 years, leading to the development of diabetes. However, there is one more reason for the development of diabetes in cystic fibrosis. Cystic fibrosis, apart from causing a local inflammation inside the ducts, also leads to the development of systemic inflammation. And systemic inflammation, we all know, can lead to the development of insulin resistance as well. So cystic fibrosis, in fact, is causing two different problems. One, it is locally blocking the duct of the pancreas, leading to local inflammation and damage to the pancreatic cells. So beta cells are getting damaged, insulin secretion is reducing. On the other hand, cystic fibrosis is also causing a systemic inflammation, which is leading to the development of insulin resistance. So if you actually see, on one side, cystic fibrosis is decreasing the insulin secretion from the beta cells, which is the primary mechanism of type 1 diabetes development. But on the other hand, it's also leading to the development of insulin resistance, which is the mechanism of type 2 diabetes. And that is why the type of diabetes that develops in cystic fibrosis actually is a combination of both type 1 and type 2 diabetes. There is some element of insulin resistance also in cystic fibrosis, but at the same time, there is also a reduction in the insulin secretion by the beta cells. So that is why the type of diabetes that develops in cystic fibrosis is both type 1 and type 2 diabetes mix. And the risk starts from adolescent period. That is why they say that the moment the child crosses the age of 10 years, a child of cystic fibrosis, start looking for the sugar, because these children, so every year annual checkups are required just to see if the child is going on to develop cystic fibrosis or not. So has now this mechanism of diabetes in cystic fibrosis become clear to all of you? So it might become, it might appear to you that cystic fibrosis are problems of the ducts. Why is diabetes developing? Because it's an endocrine problem. It's a problem of the endocrine part of the pancreas. But this is the reason why diabetes develops. One, insulin resistance develops. Other, insulin secretion also starts developing, starts reducing from the beta cells because of damage due to local inflammation. So good. So what is the reason of diabetes mellitus? I have told you very clearly what is the reason for diabetes developing in cystic fibrosis. Coming now to question number 17. Which of the following statements about childhood asthma are incorrect? So which statement about childhood asthma is incorrect? So let us see which statement about childhood asthma is incorrect. Cough, wheezing and breathlessness usually worsen at night. So nocturnal symptoms. Are in fact characteristic of asthma. So this is correct. Increase in FEV1 from baseline more than 12% after bronchodilator inhalation is a feature of asthma. According to me, this is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also correct. Inhaled corticosteroids can be given as frontline. This is also corr maintenance therapy for asthma. According to me, this is also correct. Excessive variation in lung function between visits typically is not seen in asthma. This is actually incorrect statement. What is the most important feature of asthma? It is hyper-responsive airways. See, this is a conceptual question. You have to understand. This is a conceptual question. One of the most important features of asthma is hyper-responsive airways. Hyper responsive airways का मतलब होता है typically means that the airways are so hyper responsive that they suddenly go into a bronchoconstriction and they suddenly go into a bronchodilation. So when they suddenly go into a bronchoconstriction and suddenly go into a bronchodilation, there will be characteristically excessive variation in the lung functions between the visits. So one visit the child will have a different lung function, and the second visit the child will have a different lung function. Variation in lung functions, excessive variation in lung functions on different visits of the day. In fact, even morning, evening variation in the lung functions. Remember, I told in my classes, peak expiratory flow, excessive variability in peak expiratory flow in a single day is again indicative of asthma. Because if there is no variation, that means the airways are not hyperresponsive. But one of the features of asthma is hyperresponsive airways. So excessive variation in lung function in between the visits is one of the characteristic features of asthma. So because he's asking which of these is an incorrect statement, D is an incorrect statement because D is saying that excessive variation in lung functions is not seen. Excessive variation in lung functions is seen because of hyperresponsive airways. Inhaled corticosteroids, C, is one of the drugs of choice for maintenance daily controller therapy. This is absolutely correct. B statement, increase in FEV1 from baseline more than 12% after giving bronchodilators. Yes, this is a necessary diagnostic criteria. I've told in my classes, FEV1 if it becomes more than 12%, improves more than 12% after bronchodilators, it is a feature of asthma. And nocturnal symptoms, statement A, nocturnal symptoms are definitely a feature of asthma. So which is not a feature of asthma? D is not a feature of asthma. So this was a conceptual question. If you have understood the concepts of asthma, you will never miss the answer in this question. Question number 18 says a 12-year-old boy was brought in the pediatric neuro clinic for 2 to 3 episodes of sudden involuntary muscle jerks upon awakening in the morning hours. Now this is very important. Muscle jerks occurring in the morning hours in a 12-year-old boy. Now these episodes were followed by development of generalized seizures later on. Child was alert at presentation and neurological examination of the child was normal. The child was having poor sleep. Now this is another very important clue. The child had been having poor sleep for the last 1 week. The next important clue is that the EEG of the child shows 4 to 6 hertz polyspike and slow wave discharges. 4 to 6 hertz polyspikes and wave discharges. Which epilepsy is this? Which epilepsy is this? First, let me see whether you can tell me which epilepsy is this. I'm sure seeing the answer, you have understood which epilepsy is this. Which epilepsy is this? Let me see, you can answer. Which epilepsy is this? A 12-year-old boy, an adolescent boy. Yes, very good. A juvenile myoclonic epilepsy. Very good. It's a juvenile myoclonic epilepsy. Another clue was that there was seizures in the early morning hours. That's very clue, a characteristic clue again to juvenile myoclonic epilepsies. A third clue is that the child was having poor sleep. And the fourth clue is 4 to 6 hertz polyspikes and slow wave discharges. That is a typical EEG of juvenile myoclonic epilepsies. See, juvenile myoclonic epilepsies, also called as the Jan syndrome, are commonly seen seizures in adolescents, roughly making up around, I think, 5% of all epilepsies in young adults. So adolescents and young adults, almost 5% of epilepsies are juvenile myoclonic epilepsies. They are typically seen in adolescents and young adults. Now, these seizures, typically the presentation can vary. The presentation can vary, and the presentations can be typically a myoclonic jerk, in the extremities, say for example in the hands, in the morning hours. A sudden myoclonic jerk, and I think in my classes I've shown a video of this also. A sudden myoclonic jerk, with a sudden jerk in the hand, things drop from the child's hand, and usually these are seen typically in the morning hours, especially if there is sleep deprivation. So sleep deprivation or poor sleep in the preceding few days can be a very important trigger. There are two very important triggers for juvenile myoclonic epilepsy. One trigger for a juvenile myoclonic epilepsy is sleep deprivation. If the child is not been having good sleep, then this can trigger a juvenile myoclonic epilepsy. Another very important trigger is photosensitivity, flashing lights. Flashing lights. You must have seen those light strobes, those which are there in the discotheques or even video games, those flashy lights. These are called as strobes. So if there is a sudden flash of light in the child's eye, it can trigger a juvenile myoclonic epilepsy. So these children should avoid these flashy lights, because flashy lights, almost 80%, 70 to 80% of juvenile myoclonic epilepsies have photosensitivity. And sleep deprivation, early morning seizures are very common in juvenile myoclonic epilepsies. So suppose in the exam they ask you sleep deprivation, early morning seizures. This is very characteristic of juvenile myoclonic epilepsy. Similarly, if they ask you which type of seizures are very characteristically photosensitive, so juvenile myoclonic epilepsies, they are often photosensitive seizures, very characteristic. Flashy lights, strobes, I'm sure you have seen them, which are lights. For example, in marriages, you must have seen those lights which are very bright, and they shine in the eyes. They can trigger a seizure in juvenile myoclonic epilepsies. Many times, juvenile myoclonic epilepsies in adolescents may also present as juvenile absence seizures, or even a generalized tonic-clonic seizures in adolescents. Family history is very strongly positive in juvenile myoclonic epilepsies. I did not tell this in my classes because I think for FMGs it is not required right now for FMG exams. But there is a strong family history also in juvenile myoclonic epilepsies. In AIMS exam, they have asked which genes have been characteristically associated. So a CAC-NB4 gene mutation, GABA receptor gene, GABRA1 gene mutation, and there are some more mutations of these genes can trigger a juvenile myoclonic epilepsies. So mutation in these and some more genes. CAC-NB4 gene is a calcium sensing gene, and GABRA1 is a GABA receptor gene. So mutation in these genes is known to trigger juvenile myoclonic known to trigger juvenile myoclonic epilepsy, or can lead to, not trigger, can lead to juvenile myoclonic epilepsies. So juvenile myoclonic epilepsy is a strong family history. So there might be someone in the family who may have a juvenile myoclonic epilepsy. EEG is not hypsarrhythmia. EEG is typically 4 to 6 hertz or 4 to 5 hertz polyspikes and slow wave discharges. And treatment, as you have correctly said, is valproate therapy. So valproate is definitely the drug of choice for the treatment. Juvenile myoclonic epilepsies have a much better prognosis. Neurological examination of these children is usually normal at the time of presentation. Just remember two, three things which are important. First thing is that adolescents and young adults are primarily affected. Second thing, usually these are early morning seizures. Third thing is typically they are triggered by sleep deprivation or flashy lights, photosensitivity. So around 80% of juvenile myoclonic epilepsies are photosensitive, and they are strongly associated with the mutations. So family history, CACNB4 mutation, GABA receptor mutation, can lead to the development of these seizures. This was asked in AIMS exam, I think. Which gene mutation has been linked to juvenile myoclonic epilepsies? Treatment is definitely lifelong valproate therapy, but over treatment, these seizures are very well controlled. So I hope you have understood juvenile myoclonic epilepsies well. Let us come now to question number 19. Question number 19 says a newborn on day 2 shows feeding intolerance, lethargy, and recurrent episodes of apnea and irritability. So there is a newborn who on day 2 shows feeding intolerance, lethargy, and recurrent episodes of apnea and irritability. Now this is a newborn. Examination of the newborn reveals bulging fontanelles and generalized hypotonia. Bulging fontanelles in a newborn is usually highly indicative of increased intracranial pressure, and the CSF examination of the child shows pleocytosis with elevated WBCs and high proteins, which very clearly shows that this is a case of neonatal meningitis. Neonatal meningitis. Now he's asking which of these is the most likely cause of these findings. So first I've told neonatal meningitis के causes कौन कौन से होते हैं. I've told in my classes which are the causes of neonatal meningitis. So the primary causes of neonatal meningitis are E. coli, Klebsiella, Group B Streptococcus, Listeria, and Staphylococcus aureus. And I ask students in my classes to repeat these 5 causes. So Group B Streptococcus, E. coli, Klebsiella, then Listeria, and Staphylococcus aureus. Now, where the students lack is that they are not able to recollect that group B streptococcus is also called as Streptococcus aegylecti. Aegylecti. Bacteria because low glucose, and yes, so this is bacterial meningitis, correct. Bacteria because CSF is showing low glucose and high proteins, correct. So anyway, coming back to our topic. So the 5 bacteria which are implicated in development of bacterial meningitis in newborns are E. coli, Klebsiella, then Group B streptococcus. Group B streptococcus is also called as Streptococcus aegylecti, and I have clearly told in my class it's the most common cause of meningitis, neonatal meningitis worldwide. In India, the most common cause is E. coli, but that is not one of the options here. So if E. coli is not one of the options here, I would go with Streptococcus aegylecti or Group B streptococcus as the most common cause of meningitis. Guys, just give me a minute. Just give me a minute. I'll just start in 2 minutes. Okay, so coming back to question number 20 now. Next is question number 20. Coming to question number 20. Question number 20 says the most common embryonal brain tumor in children is likely to arise frequently which of these brain regions. So you have to tell which is the most common embryonal brain tumor in children. So see, the most common brain tumor in children, the most common brain tumor in children is cerebellar astrocytoma, but it is not embryonal. First thing, it is not embryonal malignancy. Most common brain tumor in children is cerebellar astrocytoma, but it is not embryonal malignancy. The most common malignant brain tumor, the most common malignant brain tumor is medulloblastoma. And medulloblastoma is an embryonal tumor. Medulloblastoma is an embryonal tumor. In fact, if I correctly remember, FMG mein this question has also been asked previous. It's a previous year question in FMG. Which of these brain tumors is an embryonal malignancy? Medulloblastoma is an embryonal brain tumor which normally arises from the cerebellum. Arises from the cerebellum. Medulloblastoma कहाँ से आता है? Cerebellum से tumor arise करता है. So if they are asking the most common embryonal brain tumor of children, that most common embryonal brain tumor is a medulloblastoma, because it is made up of embryonal cells. And medulloblastoma classically is known to arise from the cerebellum. It can arise both from the periphery and the center, but is more likely to arise from the center of the cerebellum. I've told in my class, it is more likely to arise from the center of the cerebellum compared to the periphery. So if they are asking the most common embryonal brain tumor, then answer that you are giving C is not the correct answer. Supracellular region is not the correct answer. It is cerebellum. I don't know why you mentioned supracellular region. Supracellular region is the most common brain tumor in adolescents. Overall, most common brain tumor is cerebellar astrocytoma, but the most common brain tumor of adolescents that is diffuse astrocytoma. That is diffuse astrocytoma. And diffuse astrocytoma arises from the cerebral cortex. So, if suppose they ask most common brain tumor arising in adolescents, then you say supracellular, then you say diffuse astrocytoma is a tumor which is a supratentorial tumor. Now, supracellular tumor कौन सा होता है? Supracellular tumors are tumors which arise from above the sella turcica. Now, those are the tumors which are present near the pituitary area, and that tumor is basically a tumor which can compress the pituitary. I can lead to damage to the pituitary also, or can lead to increase or decrease of the secretions from the pituitary. Which is that tumor? Which is known to arise in the supracellular region and can cause supracellular calcifications, craniopharyngioma. So, most common brain tumor in the supracellular region. So I hope now you have understood. Most common brain tumor overall is cerebellar astrocytoma, arises from the cerebellum. Cerebellum is a infratentorial portion. Similarly, the most common malignant brain tumor also arises from the cerebellum, medulloblastoma. It is also infratentorial. It is also an embryonal malignancy. The most common adolescent brain tumor is diffuse astrocytoma. Now, this arises from the cerebral cortex, which is supratentorial. And the brain tumor which is associated with the supracellular calcifications, supracellular region near the pituitary area, that is craniopharyngioma. So please don't confuse these with one another. Question number 21. A 1.5-year-old child with 3 days history of diarrhea and vomiting is irritable, thirsty, and drinking water eagerly. So the child is a 1.5-year-old child. He is having diarrhea, vomiting, he is irritable, thirsty, and is drinking water eagerly. His oral mucosa is dry. So the moment the oral mucosa is dry and skin pinch takes time to slowly go back to its original position, it cannot be no dehydration. It is either some dehydration or severe dehydration. But in severe dehydration, the child will have a depressed look. The child will be drowsy. The child will be unconscious. The child will be refusing water in severe dehydration. In our case, they are writing the child is irritable, thirsty. So this cannot be a case of severe dehydration. This is a case of some dehydration. And for some dehydration, if the child is having a weight of 10 kgs, how do you treat some dehydration? Treatment of some dehydration will be 75 ml per kg given over a period of 4 hours. So answer will be, I don't know why D's, why are you giving D as the answer? What tells you that this is a case of severe dehydration? C and D means that these are IV fluids being given. It can only be given in severe dehydration. But does our case have a severe dehydration? He is irritable. A severe dehydration child will not be irritable. He will be drowsy. Then they are writing the child is thirsty. Will a child of severe dehydration be thirsty? A child of severe dehydration will be refusing water to drink. Getting these answers from my students, I am getting depressed now. I am getting depressed getting these answers. What makes you believe this IV fluid should be the treatment in this case? IV is only given in severe dehydration. First see the history and then decide this is no dehydration, some dehydration, severe dehydration. No dehydration cannot be the point here because the child, they say, has an oral mucosa which is dry, skin pinch is taking time to go back slowly. So it cannot be no dehydration. It is either some or severe. Severe, it cannot be severe dehydration because the child is irritable. Severe dehydration are lethargic children. Similarly, in severe dehydration, the child will refuse the water. Lethargy condition, sir. Lethargy condition, kahan likhi hai lethargy condition? So there is an answer, lethargy condition, sir. But lethargy likhi ka hai? Where is it written lethargy? Let me remove this again. Where is it written lethargy? 1.5-year-old child, 3 days history of diarrhea and vomiting, irritable, thirsty. There is nowhere it is written lethargy. हाँ, लेथार्जी होगा तब देंगे आईवी. वेरी गुड. तो आपने अभी आईवी क्यों लिखा? अभी लेथार्जी नहीं थी, अभी इरिटेबल था, थर्स्टी था. सो दिस इज सम डिहाइड्रेशन. ऐसा मत करो प्लीज. डू नॉट गिव आंसर्स लाइक दिस. This is a very important exam that you are giving, a very important phase of your career. Jumping to an answer without thinking about the concept will end up giving a wrong answer. आप खुद identify करो, you are yourself identifying that answer will not be IV. Answer will be ORS 75 ml per kg over 4 hours, so 750 ml over 4 hours because the child is 10 kg weight. Okay, question number 22. A 13-month-old child is brought for evaluation. So this is a child who is a 13-month-old child and he's brought for evaluation. The mother reports the child has been having chronic diarrhea recurrent abdominal pain, abdominal distension, and vomiting, most prominently after meals. So the child is having chronic diarrhea, he's having recurrent abdominal pain, he's having abdominal distension, and he's having vomiting, and most of them are occurring after meals. He's diagnosed with celiac disease. Now he's saying all of the following are incorrect statements about celiac disease except. So he's asking basically which of these is a correct statement about celiac disease. So what is the correct answer? So extraintestinal manifestations can be seen. According to me, this is correct. There are a lot of extraintestinal manifestations seen in celiac disease. Iron deficiency anemia, joint problems, skin manifestations, short stature, they all can be seen in children with celiac disease. Children usually show a normal growth pattern. I just now told you short stature is seen in celiac disease. So this is an incorrect statement. This is not a correct statement. This is an incorrect statement. Children show a normal growth pattern. I've told in my classes, one of the causes of short stature in children, remember proportionate, disproportionate. In proportionate, one of the causes is celiac disease. So short stature children. So children with celiac disease may not show a normal growth pattern every time. HLA-DQ6 is seen in almost 94. No, HLA-DQ2 and DQ8 are seen in most children with celiac disease. So this is also an incorrect statement. HLA-DQ6 is not associated. HLA-DQ2 and DQ8 are associated with celiac disease. And finally, diagnostic GI endoscopy and biopsy are taken from the ileum colon. Why is this again a wrong statement? Because celiac disease is a small intestinal disorder. तो colon से कैसे biopsy लेंगे? Again, just apply your mind concept. Celiac disease is a small intestinal disorder. So colon से biopsy लेकर, by taking a biopsy, intestinal biopsy from the colon, you'll get nothing. Because the problem primarily happens in the small intestine. Duodenal biopsies are primarily required in celiac disease, which show those classical features that I've told in my classes. Intraepithelial lymphocytes are increased, villus flattening is there, crypt hyperplasias are there. So it is usually duodenal biopsy. The only thing that is correct is A. कॉलोनी नहीं, कोलोन हेड से हाइड हो गया था. D is not correct. फिर पूछ रहे हो D is correct. D is not correct. D is incorrect. इतना समझा दिया after telling so much. Now also I'm getting, sir, is D correct? D is saying diagnostic GI endoscopy and biopsy are taken from colon. No, it is not taken from colon. What will you get by taking a biopsy from colon when the problem is in the small intestine? Colon is a part of large intestine. Question number 23. A 6-year-old girl with periorbital edema and pathological proteinuria is diagnosed with nephrotic syndrome. So this child is a case of nephrotic syndrome. Despite the use of prednisolone for 6 weeks, urine protein excretion remains significantly high. So the child was given prednisolone steroids for 6 weeks, and despite that, the proteinuria is still very high. Renal biopsy is further advised. What findings will you get on renal biopsy? So this is a case of nephrotic syndrome. So in nephrotic syndrome, there will be proteinuria, and the child was having pathological proteinuria. Very good, very good. Minimal change disease, very good. मिनिमल चेंज डिजीज में प्रेडनिसोलॉन दिया 6 वीक्स तक, एंड 6 वीक्स तक प्रेडनिसोलॉन जो है वो रिस्पॉन्स नहीं आया टू प्रेडनिसोलॉन. इज दिस, कैन दिस बी मिनिमल चेंज डिजीज? नो. मिनिमल चेंज डिजीज क्लासिकली रिस्पॉन्ड्स टू प्रेडनिसोलॉन. See, let us go like this. Proteinuria in a child, whenever there is proteinuria in a child, there can be many reasons. Proteinuria in a child can be because of, let us say, physiological proteinuria, or let us, rather than saying physiological proteinuria, let us say transient proteinuria. सो ट्रांजिएंट प्रोटीनूरिया, अगर प्रोटीन आ रहा है यूरिन में, ट्रांजिएंट प्रोटीनूरिया, transient proteinuria can occur in infection, can occur in fever. Transient proteinuria can occur because of exercises. Transient proteinuria can occur because of dehydration. So transient proteinuria is a proteinuria which is very transient. अपने आप आता है, अपने आप चला जाता है, comes for some time and then goes back on its own. That is one of the causes of proteinuria in children. The second important cause of proteinuria in children that you should know is orthostatic proteinuria, which is also called as postural proteinuria. Again, since I was telling about nephrotic syndrome, I thought in this session, let me tell you about proteinuria also. So, orthostatic proteinuria, postural proteinuria. Here, proteinuria starts appearing with change in his posture. So, when the child is lying supine, leta hua hai, there is no proteinuria. When the child is in a standing, upright position, then proteinuria starts. So, this again is one of the causes of proteinuria in some children. However, the most important cause of proteinuria are glomerular, primary glomerular disorders. Primary glomerular disorders. And the most important glomerular disorder which is associated with proteinuria is minimal change disease. And that is why we say minimal change disease is the most important cause of nephrotic syndrome in children. It's also called as lipoid nephrosis. So minimal change disease is therefore considered to be the most important glomerular disorder associated with nephrotic syndrome in children. However, when minimal change disease is there, it's a cause of nephrotic syndrome in almost 80% to 85% cases. But when minimal change disease is there, child usually will always respond to steroids. So steroids are the drug of choice for treating minimal change disease, and proteinuria disappears in minimal change disease. In our case, there is steroid resistance. So that means now we will not think of minimal change disease. The second most common cause is focal segmental glomerulosclerosis. This is the second most common cause of proteinuria, pathological proteinuria, nephrotic syndrome in children. So जैसे ही steroid resistance हम सोचते हैं, whenever we start thinking of steroid resistance, the first disorder that should come to our mind is focal segmental glomerulosclerosis, and another disorder that should come to our mind is membranoproliferative glomerulonephritis. When till the time it is steroid responsive nephrotic syndrome, the cause will always be minimal change disease. And since almost 80 to 85% nephrotic syndrome responds to steroids, so almost 80 to 85% nephrotic syndromes are minimal change disease. The problem is when we start having a steroid resistance, then it cannot be minimal change disease. Then it is either a focal segmental glomerulosclerosis or a membranoproliferative. और ये तभी पता चलेगा, you will only come to know which of these is the cause when you do a renal biopsy. So those typical changes of focal segmental glomerulosclerosis and membranoproliferative glomerulonephritis can be identified. Among the two, I would go in for focal segmental glomerulosclerosis as the most important cause of steroid-resistant nephrotic syndrome. Then apart from these, there are some glomerulonephritis also, which can lead to, in which proteinuria can be very prominent. So although, as you know very well, glomerulonephritis is classically associated with hematuria, there are some glomerulonephritis where proteinuria can be very prominent. For example, IgA nephropathy. Remember, in my classes, I always tell for the treatment of IgA nephropathy, steroids can be given. ACE inhibitors can be given. Remember, I've told in my classes, angiotensin converting enzyme. So why are we giving steroids? Why are we giving angiotensin converting enzyme inhibitors, RAS blockers, renin-angiotensin blockers? They are anti-proteinuric drugs. So these anti-proteinuric drugs are given in IgA nephropathy because IgA nephropathy has many times considerable amount of proteinuria. Obviously, hematuria will be there, but there is considerable amount of proteinuria also in IgA. Similarly, PSGN, post-streptococcal glomerulonephritis, there can be considerable amount of proteinuria. Lupus nephritis. There can be considerable amount of proteinuria. Similarly, in cases of Hinox-Schönlein purpura, remember I said renal involvement can occur. So there can be considerable amount of proteinuria. Many tubulointerstitial disorders. Many tubulointerstitial disorders, such as tubulointerstitial nephritis, can also be causes of proteinuria. So these are some important causes of proteinuria: transient proteinuria, orthostatic proteinuria, primary. Now this is nephrotic syndrome. This is nephrotic syndrome, the most important cause of proteinuria, pathological proteinuria. And as I said, 80 to 85% have minimal change disease, but they are all steroid responsive, mostly steroid response. Steroid resistance cases mostly have focal segmental glomerulosclerosis or sometimes membranoproliferative glomerulonephritis. Then there's some glomerulonephritis which can present with proteinuria as a prominent finding. And then finally, tubulointerstitial disorders such as tubulointerstitial nephritis can also present with proteinurias. I hope now you have understood. All of the following are components of kangaroo mother care. Now, kangaroo mother care, I've told in my classes, is a standard of care. It's a standard of care for keeping low birth weight and preterm babies warm. Now, kangaroo mother is a pretty simple question. I think you should all be able to answer it. Kangaroo mother care, the three components typically are early initiation of exclusive breastfeeding, prolonged skin to skin contact between the mother and the child, although it can be given by the fathers also, the skin to kangaroo mother care, and then early discharge from the hospital when the child is stable. So the thing that is not given in kangaroo mother care, is not a component of kangaroo mother care, is cleaning the periumbilical area. This is not a component of kangaroo mother care, and I'm sure you should also all be able to answer this. So kangaroo mother care components are early initiation of exclusive breastfeeding as early as possible, prolonged skin to skin contact between the mother and the baby, and early discharge from the hospital when the child is stable. Yes, so this is all right. But problem was where there were concept based questions, you people, many of you were not able to answer those concept based questions. ये तो simple question है. This is a very simple question. This is not a concept based question. So don't feel very happy by answering this question. And again, a very simple question, which I'm sure you all should be able to answer it. Over the last few years, LISA is a neonatal technique that has emerged as an effective and relatively less invasive ways of delivering which of the following in newborns. So the established technique of that, administering that drug was Ensure, but the new less invasive technique were LISA and MIST. Less invasive surfactant therapy or surfactant administration, and finally minimal invasive surfactant therapy. So this is usually for surfactants. इसका तो आंसर कर ही दो. So again, what I've seen in my this 25 most important questions, I've touched upon important topics, but what I have seen is that there is some slight lack in areas where concepts are required. Where concepts are not required, you will easily answer. But where a little concepts are required, please try to rule out the choices and then come to the correct answer. Don't be in a rush. आपको ध्यान रखना, you have to be very careful that if you are in a rush, you have to wait for another 6 to 7 months to again give the exams. So why are you wasting those 6 to 7 months by being in a rush? Just think about those concepts. And I don't think there should be any problem. Rule out the choices one by one and you'll come to the correct answer. Anyway, so I don't want to keep you waiting. It's been a long 2.5 hour session. Thank you very much. I again wish you all the best for your 28th June exam, and I hope this session was useful and you will be able to make me and my other colleagues, faculty colleagues proud by clearing these exams. and then subsequently your NEET PG exams as well. So thank you very much for attending the session. I hope you benefited with the session, and all the best for your exams. Bye bye.